All right, we are live again for a physical therapy live event here at Midwestern University. Glad those of you who are joining are able to be with us today. We're gonna give a few minutes, maybe a minute or two, for folks who are joining late to get online and hopefully join us for our chat today. So we'll maybe give it till we hit the minute mark, and then we'll introduce ourselves and then get on with the talk. But in the meantime, if anybody's watching live, I'd love to hear if there's where you're coming from, where you're watching from in the chat. Also, if you have any questions during our talk today, feel free to put those into the chat, and Tom and I will definitely try to answer those as those come along. So don't hesitate. This is to hopefully help you all get a little bit better understanding of some options you have for disc issues, as we unfortunately, many of us will encounter them in our lifetimes. So
we have already.
I'll share my story as well of my lovely history with this. But why don't we get started? I'm going to introduce myself. My name is Dr. Mark Kargela. I'm a physical therapist of 20 years. I work as a clinical assistant professor here at Midwestern University's PT Institute here in Glendale, Arizona. My specialization is kind of spine, chronic pain, and orthopedics in general. Love to work with some of the chronic conditions, and disc issues definitely can become one of those. So looking forward to sharing some of that with you all today. Tom, if you don't mind introducing yourself.
Yeah, I'm very similar, except I'm on our sister campus here in Downers Grove, Illinois. I'm a clinical assistant professor here. Spend a lot of my time treating patients, also orthopedics as a specialty. My other time is dedicated to some teaching and the orthopedic content to our physical therapy students, and a little bit of clinical research when I have the time. So, but yeah, I'm looking forward to this. I think it's just an incredibly common thing. I mean, you and I can easily relate on the many patients we've seen dealing with disc-related issues, whether it's in the neck or the low back. Not to mention, both of us have had similar injuries ourselves, and can really speak to the challenges and how that feels and the recovery and so forth. So, yeah, looking forward to this.
Yeah. Why don't we start off and maybe have just to kind of talk a little bit about what we're talking about when we talk about disc issues, just so the audience has a good understanding of kind of what we're going after. There's a myriad of different maybe conditions around the disc, but we may focus on a few today. But what are we going to be talking about today, Tom?
Yeah, so disc issues. It's not like there's just a single pathology in discs, and that's all we need to worry about. I mean, the disc is a structure in the spine from the neck all the way down to the base of the spine, and it's basically a quick and dirty way of describing it is a shock-absorbing like structure between each vertebrae. But different things can happen, of course, relative to injuries or disease. But I do think that as we were preparing for this and kind of generally chatting of what we're going to focus on, our thought process would be to touch on a lot of it, to touch on disc herniations and what that may present like, and kind of what, things to look for, in addition to maybe degenerative disc disease, which is another common term that many folks listening to this may have heard or may have actually discovered themselves. So we can touch on those. They do present, differently, of course, and the treatment can be varied. But really, I think my goal and our goal is to just let someone out there hear something that helps guide them personally, or helps guide them and their family member, or just gives them even terminology to kind of understand on a basic sense. We're, of course, not going to spend time here telling you exactly how to treat things and so forth. But I do think getting that little pearl of something out of this is really what our goal is. Yeah. So, and if I wanted to expand a bit further, the disc herniation specifically is when the disc itself is injured. Usually there's a trauma associated with it, a lifting or bending sort of injury. And the disc, through either mechanical reasons or through inflammatory reasons, can really irritate a nerve that's coming off the spinal cord. And so oftentimes people will be experiencing pain radiating in their limb, whether it's their arm or their leg. And, kind of on a different spectrum with a disc-related injury would be the DDD, the degenerative disc disorder, which, Mark, if you want to comment on that in your experience.
Yeah, let's touch upon that. And I think that kind of goes into our next topic a little bit, where, the one thing I wanted to just point out, because I think it's been helpful for patients that we've talked to in the past too, because there is a boatload of information out there about discs, and Dr. Google can be a friend and an enemy to a clinician as far as there's a lot of bad information out there as well. I think some of the things that's been helpful that we've seen with patients is just kind of putting it in perspective of what is kind of normal as we age. And I bring up this graphic because it kind of helps, I think sometimes it kind of takes a little bit of the fear out of disc issues, just because we see here, this is a graph that kind of plots our age on that x-axis from all the way to 20 to 80 years old. And the one I would point out is this light blue line that kind of is on the top end of the graph. And you can see as this is in our 20s, these are disc bulges. You can see that they're pretty common, 30% of folks in our 20s. And these lines just gradually get bigger over time. Now, disc protrusion, maybe not as common, but even the research shows that those can occur asymptomatically. So just recognize this graph is all people who have zero back pain whatsoever. And we're seeing disc degeneration is probably the biggest issue. And those of you who may have tuned in last time when we talked about arthritis, I'd use the same analogy that I use with arthritis to disc degeneration. It's kind of like calling my scalp degenerative scalp disease, as far as it's a normal age-related process to an extent. Now, it can get severe. There can be genetic factors, metabolic factors, and things. So I don't want to just completely poo-poo it, but it is a normal finding in our spine as we age to see that. So disc bulges, disc protrusions, and things like that. And there are things that, again, with these people being pain-free, we look to see, can't we just bring folks into episodes of acute back pain that may be accompanied with a new finding on film, be it a bulging disc protrusion or herniation, maybe some degenerative findings that are found on film. The nice thing that the research has shown us is that it's amenable to conservative care. And we're going to go into some of the details today. So anything you'd add to that, Tom?
Yeah, no, I just think it's a great illustration. I mean, we certainly start this topic off and this talk off with like, disc injuries, and they can be bad, and what can we do about it? And it's so dire and everything. But, I do really like this point, is that this can happen to asymptomatic people. Our bodies change as we get older, and just because it shows up on an image doesn't mean that you're done for and that you're destined for surgery or you're destined to have an impacted life. It should be encouraging to people out there to see that, like, this isn't the answer. This isn't the only thing we need to look at, especially because a lot of this data is coming from asymptomatic people. And I mean, it's similar to our talk on arthritis and how imaging is a wonderful, wonderful tool, but it certainly is not the whole picture, and it's really just a piece of the exam. Imaging doesn't equal symptoms, and I think that that's just a really important pearl that hopefully some people recognize. Because how many times, Mark, if you had a patient come in with their MRI and they say, I have disc bulges and they name every single level, but your exam doesn't correlate to that. And so then you have to find a way to educate and at least provide your thought on it, your opinion on it, whatever you want to say about it. But and slowly have this patient understand that it's more than just that snapshot picture.
Yeah, no, definitely would agree. I think just the terminology and some of the connotations of it. I think traditionally we hear disc bulge, disc herniation, and people really have pause. And understandably, there's just a lot of fear and kind of scary information about it. Do I need surgery? All these things, which we'll touch upon a little bit later. But I think really de-threatening it and validating the understandable concerns that people have around those, because there's a lot of scary information out there, and then giving them a path to show how conservative care can help. And again, we'll touch upon that a little bit today. What we wanted to do also is just talk a little bit about what symptoms may look like. I'm going to share a little bit about my symptoms when I had my herniated disc. Tom alluded to how inflammatory mechanical components, sometimes just the inflammation around a disc, can really irritate the nerve that's heading right outside, right by that disc down in towards your leg or arm. Sometimes it can be herniations that mechanically will put compression on nerves. When I first had my symptoms with the disc, I had an episode of stiffness of the back that led into this. This was a low back issue that on a drive to Minnesota from Michigan, where I was living at the time, all of a sudden I had this stabbing pain in the outside of my hip that progressively started radiating down my leg. And by the next day, I lost sensation to the outside of my foot. The reflex that we test at the base of the leg, your Achilles reflex, that was gone. And I couldn't raise up on my toes one time on that leg. So I had significant weakness in there. So at that point, I knew, because being a physical therapist and seeing these regularly, that I had an L5-S1 herniated disc. And did try to practice what I preached, and definitely was freaked out and was considering, gosh, am I going to be able to recover, heal, and do these things and get back to where I want to be? Thankfully, my wife, who's also physical therapy, talked me off the ledge of like, oh gosh, the world's over, because they are painful. Anybody who's had one of these, those of you who are listening, who's had a herniated disc or disc issues, they can really grind your life to a halt, where you're not sleeping, you're in severe arm or leg pain, and it can be a very trying 1 to 2 weeks, sometimes longer, that can get you in some desperate states of mind. I definitely can relate to patients when they've come in very scared, freaked out, and that's often a time where we can help them start navigating a healing process and learning some movement strategies and things to help. But in that situation, any movement was triggering spasms, coughing, sneezing, bothered. It even hurt when I went to the bathroom to produce pressure to do that. That might be TMI, but there you go. Anything else you think you see quite a bit? I mean, I focus more on the low back, but neck obviously is an area where the disc issues can happen as well.
Yeah, I mean, the variety certainly is there and sort of how it can present, but some of the things that you touched on, I think I want to highlight. Oftentimes there isn't a known injury. I mean, yes, we talk about bending and twisting for the low back and often do it, but in your case, maybe prolonged sitting in a driving position, maybe you twist it a bit in there. It doesn't take much sometimes. I often suggest that you could be picking up a toothpick off the floor, and that could be the straw that breaks that camel's back and really kind of sets this cascade. But yeah, symptoms, common ones tend to be burning and stinging. It can be radiating through the limb. It can be with or without spine pain. And I think that's an important thing to comment on as well. How many times again, Mark, have you talked to someone and be like, I think it's coming from your lumbar spine, L4, whatever you say, but I don't have back pain.
Yeah.
But your exam is really identifying this particular spinal nerve that's affected and kind of motions within the spine that create or dissipate the pain, leading you to think that. But I think that's important, that it's not always accompanied by actual local spine pain. Yours started in your lateral hip region, not your low back. You can get sensation loss. You can feel numbness, tingling, pins and needles. Sometimes it's this throbbing, achy feeling. It can be a very particular pattern in the arm that you feel that is kind of specific. So yeah, a lot of those symptoms can exist. I think some of the more troubling ones are the things you mentioned is weakness. Mm-hmm. And this might get us into our next topic here, but even more concerning is when you start to see progressive neurological symptoms, especially rapidly progressing symptoms. So one good example is someone with, I just had a case of this. They had a radiating pain starting in the scapular shoulder region, coming through the arm, and then rapidly developed atrophy of their thenar musculature. So it just started to waste away very quickly. And so that's one of those things that as health professionals, maybe we see and go, oh, wait a minute, we have to get this looked at now. So one of the questions out there may be, okay, I get these symptoms. You're telling me conservative stuff may help. But maybe something like atrophy or this progressive rapid neurological symptom is more or less an urgent referral at that point. So it can be mild stuff to severe stuff. And really a therapist is a really good position to kind of see where we're at and see what the next phase may be. Is it conservative treatment? Is it not? Is it a referral? And so some of those decisions have to happen. Yeah.
Yeah. Kind of with when you should seek care. I mean, obviously, in the early stages, sometimes a physical therapist can interact with you and teach you some movement strategies to hopefully maximize the healing process to occur. And we'll talk about discs healing and that in a second. But to kind of piggyback with what Tom said, when we're talking about the low back, a common red flag screening we'll look for is, it's called cauda equina syndrome, but it's basically the nerves at the base of your spine that innervate your bowel and bladder, if they're getting affected. Also, for males, a common side effect that often isn't discussed is sexual dysfunction, erectile dysfunction that occurs as a result of the cauda equina or lower lumbar nerve roots. We will ask if people are having trouble controlling their bowel or emptying their bladder, because that can be signs of a serious condition that we usually will refer immediately.
One way I like to ask patients too with that one in particular, because if you're like, one of the major red flag symptoms with cauda equina is described as numbness or tingling in the saddle region. Of course, that doesn't mean anything to anyone. So really anyone listening out there, if it feels numb or tingly when you clean yourself in that area, that's a nice way for people to go, oh, actually, yeah, ever since I hurt my back, that's gotten worse. And sometimes people don't connect the two, but that can be a quick referral.
Yeah.
And certainly like bowel or bladder loss, as you mentioned, is a tough one.
Yeah, and Tom already touched upon the progressive neural loss, which is definitely when you rapidly lose neural function. Although I rapidly lost mine, and there's discussions in the literature of if you do you need a rapid surgical consult or not, and there's really not an agreement. I think if the thoughts of these do recover over time. Mine recovered. I do still have a mild sensory deficit in my outside of my foot. I'm not going to say it's perfect, but I am back full fitness, full activity, full doing everything without any limitations, without a surgical consult. There is definitely a time and place for surgery, but they can recover and heal well. Sometimes they don't, due to maybe there's mechanical issues, vocational things we're doing at work that just really don't allow the area to rest. There can be a variety of reasons why discs may kind of stick around past the acute phase. Sometimes discs get blamed for the symptoms, and they might be just one of those findings on film that isn't part of the clinical presentation, as Tom had alluded to earlier. But Tom, you had kind of looked into some of the statistics. I know we talked about it as far as like disc healing. What's the thoughts on disc healing? It's a common question we'll get from patients of like, can this thing heal? What's your thoughts?
Yeah, so if we take that definition of healing, I'm not about to put my flag in one way or the other, because that is debatable. Does a structure actually heal? Again, we could probably spend a few conversations on that. Regardless, it can become asymptomatic. And I think in functional and risk of re-injury is maybe lessened as a result in just a very positive direction. And oftentimes, I mean, the recent article I actually read, kind of looking into this, was that the majority of cases can resolve within 6 weeks almost on their own, and I think with just acute management, positions of relief, using maybe some over-the-counter things, some ice, whatever, just letting things calm down acutely oftentimes can help resolve disc issues within those 6 weeks. Now, as they become more severe, that's when more directed treatment comes into play, and that's why you or I, a therapist that has an individualized plan. And so a lot of our role is maybe finding creating a good environment for that disc to recover, or at least to calm down and to decrease some of those inflammatory properties that are irritating that nerve. But again, whether it heals or not is sort of a larger question. But I do think it can become asymptomatic, and in majority of cases do.
Yeah, it was interesting. I was peeking at some of the literature on it, and there's a study that was in a pain physician journal, so that it's actually called Pain Physician, but it looked at the rate of, we call it spontaneous resorption, where your body just healed it, where it was once on an MRI and it no longer appears on MRI. And they actually showed for lumbar disc herniations. Now, this isn't necessarily bulges. Herniations are when it escapes the discs and kind of protrudes. That's that lumbar protrusion, because bulges are where it's just pushing out on the container of the disc, but the container is still intact. The protrusions, actually, the bigger the protrusion, that has a very good chance that it will be completely healed and resorbed. I think the statistics are 66% of lumbar disc herniations. This was lumbar spine, so I can't speak for the cervical spine or the neck, but the low back discs, 66% will kind of spontaneously resorb over time. So they can heal in that instance, but I do think there, rightfully, Tom has some discussions on whether they always heal or not. We don't necessarily 100% know. And in the end, the literature would say there's a lot of stuff on film that can stay present, yet if the person's back functioning 100%, symptoms are gone, that disc can just be there, and it's not a threat to anything anymore. I mean, there's definitely thoughts, okay, can it recur? Well, if you get back into bad movement habits and things that might put, repetitive prolonged loads and strains on things, possibly, but I think that's obviously what we try to work with patients, is to help them get through that healing process and learn some good spinal habits to keep things moving well in the long term. So
I think that's a good point, is really kind of trying to get people that are maybe recovered from one, but have this underlying fear of but the disc is still herniated or the disc is still bulging. And I think that takes a little bit of education, because you certainly don't want them being fear of movement, right?
Yeah.
Movement is the basis of what we do. I mean, that's how we help people, is we get them to move. And so we certainly don't want that to be a barrier. So I do like that point, is decreasing that fear that, the presence of it may still exist, but the symptoms and the management and the function, all is fantastic. So,
yeah. I think just one last thing to add to that, I with your thoughts on fear, because that's a common thing of like, people are very fearful to move or bend. And sometimes a common issue we work with people is they've developed this, I just avoid my back with all of life. And the analogy I always live with, or I always use with patients on that, is like, your skin will never get tolerant to the sun if you live in a cave. Like, your back's never going to get tolerant to movement if we refuse to move it. And there's on good reasons. There's a lot of scary information that people get. There's a lot of scary spine models out there that make it look like if you bend, you're going to squish out gel out of your disc, and it's going to, those things heal, and your spine can become safe and robust and resilient to bending and lifting. There's a lot of power lifters and professional athletes who go to some very vigorous bending and twisting of their spine after a herniation. So, but that's something a physical therapist can work with you on as far as
and a lot of our treatment is using these movements to sensitize the whole area. I mean, it's not even just about the structure itself, but even the nervous system, even the is involved in this, in pain management, understanding that stimulus doesn't equal pain. So movement, creating a stimulus, doesn't always have to be pain, and that's a whole other conversation that we could get into. But yeah, movement good is kind of my point here. Don't be afraid to move if you've been previously injured. So
yeah, so getting into some of the treatments, because that's a common question that I've had people who are like stopping me in grocery stores or whatever, and or chatting at some of the outings in our community about what you guys do for a disc issue. Like, what does physical therapy do? And I'll touch upon one, and then I know Tom has some other options as far as things that we all can use as physical therapists. But there's a common repeated motions process. It's called the McKenzie method. It's not, you can get certified in it. You don't necessarily need to be certified in it. You can just learn how to apply repeated movements that help decrease pain. Can be a very effective, it's pretty highly researched method around the spine to help with peripheralizing pain into the arm and leg, depending on if it's, again, neck or back. So it might be a little bit of some repeated movements that we teach people to use on a regular part of their day to help manage and control pain and return their movement back to them. And then there's a variety of other hands-on and maybe even manual therapy techniques and exercise techniques. Tom, do you want to touch upon that?
Yeah, so therapists can approach patients in many different ways with similar outcomes, and I think that that's just the nature of healthcare in a lot of ways, especially conservative healthcare. I'm a big fan of repeated movements. I think that with very specific disc herniation related issues, oftentimes your therapist may have you repeat certain spinal movements that help, as Mark said, bring your pain out of the limb and centralize it, and then hopefully disperse it. But my approach to back pain in general often is what's called the treatment-based classification. Basically, it's whatever treatment works, I'm going to go for it. So, and some of those common treatments are these repeated measures. Then there's the manual therapy technique you talked about, whether it's mobilizing the spine or manipulating it. And you can also do some core strengthening and stability exercises, very common, something anyone out there listening might be involved in to create stability to the spine. And then there's all sorts of other modalities that you may see out there. I will say that things like ice, heat, electric stimulation, a lot of these are pain management. Whether or not they're addressing the underlying challenges in pathology is I would argue they don't. But certainly if it helps you move and it helps you kind of get into the next phase of your recovery, then I'm all for it. Even things like massage, if a muscle's spasming, you might get some of that. So yeah, there's a lot of variety out there, and many of it can be effective.
Yeah, we had a question from LinkedIn about would a certain mattress or sleeping position help or hurt in the healing process? I'm personally, because I've had patients who have spent tens of thousands of dollars on pillows and mattresses and different things. We try not to get to that point unless they're in just a really tough situation with a really poor sleeping situation. I don't necessarily go to that new mattress, new bed recommendation right out of the gate. I do think there are sometimes sleeping positions we can teach with how you can position with pillows. Sometimes prone laying can be more comfortable for some discogenic things. It's hard to, I know there's always going to be the folks who proclaim this position is the best and only position for it, but it's an individual thing. So everybody's different shaped and different sizes, taller, shorter, and different body, morphology, that we might recommend different positions for different people and different positions based on how their symptoms respond to what we see when we mechanically move them and position them in the clinic. So there's not maybe one perfect go-to position to sleep in, but it's something we can definitely help folks with to maybe find something that works well for them, because sleep comes very challenging when you're dealing with active disc issues. it can make it to a tough thing. So anything you do to find comfort in sleep is a good thing. Anything you'd add, Tom?
No, position of comfort, right? If one thing doesn't work, you can always try another thing. There isn't the one gold standard of a sleeping, surface. And I find that if I'm not sleeping in anything but my own bed, my back kind of hurts. So maybe I'm approaching middle age faster than I thought here. I don't know.
Yeah, our bodies do tend to get curmudgeon-y and a little less responsive to variability in sleeping positions. Steve had asked, lower back stiffness, is this a sign of a potential issue? Can I do something to strengthen my back? What do you think about that, Tom?
Yeah, stiffness is not always like the prequel to having a major injury. Stiffness, though, can be a result of lots of sort of things, whether it's muscle tension, even inflammatory kind of processes, mild to more than mild. But it's not a precursor. So, I think stiffness can be addressed with movement. You'll hear us say it over and over again. Movement is good. And if you're not sure how to move and what's safe and what works for you individually, even if it's a single session with a physical therapist, explaining what are your objectives? I want to be able to move. I have stiffness in my back. What can you teach me today to help me move better and maybe address the stiffness or at least prevent it from possibly getting worse? The same holds true with strengthening. We are well equipped with identifying certain muscle groups, your deep core muscles, your superficial muscles, your hip musculature, all the way up through your scapular, your neck, your deep neck flexors. All these fancy names for things that we address constantly can be a simple, single, quick conversation of here's what you can focus on to help address this weakness if we identify that.
Yeah, I think you speak about stiffness, not necessarily a reason for concern, but having good varied movement through our body is just good in general. If you're feeling stiff, having some good mobility work. I do get questions, what are the best exercises for low back pain? And people want to have like a list, a sheet that these are the ones. Again, it's more of an individual thing. What are the goals of that person? Like Tom had alluded to, what do they want to do? If it's somebody who has to pick heavy objects off a floor, then we might even get into deadlifting and doing things where we got to get the back tolerant to that. And we got to find, well, where are they at right now? Where are their goals, and plot a program to get them there. That might be, if it's a very active, fit person or somebody who's very high level function, might be one session of coaching and teaching and giving them some good instruction to go on. If it's somebody who's dealing with a lot more challenges and more, comorbid issues, we may see them formally in therapy for more sessions to get them to meet their goals.
In addition to that, too, just to comment on it, sometimes people have difficulty controlling their body, right? And that's all. That can be common, right? I don't know how to activate this muscle. You say core, I don't know what the heck you're talking about. So we can get even fancier sometimes with some biofeedback things and really visualize and have the patient see their core muscle contract real time in front of them on a screen. And then that helps reinforce, okay, now I get it. So that might take a couple sessions or whatever the case may be, but individualized, I think, is key there.
Yeah, good points. The core muscle discussion, Erwin, thanks for chiming in. How important is your core muscles in maintaining a proper posture? This is when I kind of have a little passion on this topic, because there is a lot of you have to sit and stand in this rigid, perfect plumb line posture. And a lot of the research is saying your best posture is probably your next posture. As far as you're varying it up, you're not getting stuck in one position, whether it be standing. And I've had folks in the military where they're standing at attention for extended period of times, which technically is good posture, yet it starts bothering things. And then obviously the predominant postural issues are people that are in prolonged strain in more of the sitting desk type stuff. So as far as core muscles, I think getting stronger around your back in general, whether it be the abs, the back muscles, and everything in between the core, is kind of this nebulous, all-encompassing muscles that surround the spine type thing. Definitely getting stronger and more robust in your ability of your back to take loads through strength training and core muscle training. Only other thing I'd say with that, and I'll let Tom chat, is sometimes we can take core training too far. Like I get some patients who are so fearful to move their back, they're bracing their back with every, like picking a piece of paper off the floor, they're tensing their stomach, tensing their back. They move everything with tension. And the studies really show how we can see folks with chronic spine pain and those that don't have chronic pain, or how tight they hold their body and tense. And folks who have chronic spine pain often hold themselves in a very contracted, tense way, which isn't, if you think about movement prior to having some of these injuries and pains, we don't think about it, we don't tense it, it's free flowing. Now, there might be some tension if we're going to lift a heavy object off the floor, but it shouldn't be there when you're doing light, basic daily activities, which again, is when sometimes core stability can become actually a hindrance. I've had some patients where the biggest issue of their pain was because they're holding their body tense all day. Try to clench a fist for a full day and see how well your forearm feels. It's not going to feel good. And that I get people who are clenching their core, 24/7, which is not a healthy habit to get into. But what are your thoughts, Tom?
Yeah, I agree completely. One thing I'll kind of highlight that you mentioned that I think is important is that it's not about a static posture that's the best. It's about variety. It's about moving. Again, now obviously a forward head, forward slouch, kind of like this prolonged, is not great at all for most cases. But it's really about the variety. And I think it's the question with Erwin, thank you, is not necessarily about the raw power and strength of your core. It's what we would refer to maybe as neuromuscular re-education, which is really getting your muscles to cooperate with each other and with your joints and with your spine to kind of activate in the right sequencing or pattern or sort of the right degree in which helps support your body in gravity positions versus I want a six pack and I want to have the most raw power of core. That may not change your posture, right?
Yeah. Very good points. Let's get back into a little bit of, we talked about exercises. One common question that we get is, when is an MRI needed? That's common. Some patients won't come to a physical therapist unless they have an MRI. They don't feel like it's safe to do so. What are your thoughts on the MRI situation, Tom?
Yeah, again, I kind of speak out of both sides of my mouth with this one. I keep mentioning that I'm a fan of imaging, and MRI is the gold standard in imaging of lumbar disc, or not lumbar, but spine disc pathology in most cases. And it can be a certain benefit to my exam and to many physical therapists' exam, and certainly helps a patient understand maybe the anatomy and sort of the pathology of what they may be dealing with. But as I said before, it is a snapshot. And sometimes it can be misleading if someone's perseverating and just hyper focused on the disc bulges at every level that may not be present in the actual musculoskeletal exam we do. Now, when is an MRI actually needed? So I often direct people to an MRI if I notice any of those red or yellow flags that make me nervous. I often direct them to, which we've already mentioned, but I've also directed people to an MRI if my conservative treatment is not effective and things are in fact worsening, or I direct them to another person that could care for it, whether it's another therapist or another health professional or a physician or an orthopedic. Someone, if my scope hasn't addressed it the way we need it and it's worsening, we need to move forward some way else. So those are the main, probably reasons that I would be doing it.
Yeah, I would echo that. I think if you're seeing some of the progressive rapid loss of strength and function, sensation and strength in a extremity, or you're seeing those ball or bladder changes that we spoke to earlier, do you need one to start physical therapy? No. We are skilled to be able to examine and determine if it is an emergent, like we need an MRI case. Whether it's a bulge or a herniation, it doesn't necessarily change how we're going to treat you. We're going to treat you based on what movements and exercise and activities start reducing symptoms and get you back to the things that are important in life. And it doesn't change whether that disc is bulged, herniated, or in between. It's just going to be, a matter of finding where you're at that moment in time with movement and pain, and plotting a unique program to your specific individual needs that gets you back on the path to movement and get you back on again to the things in life that are of concern for you. So yeah, I would say MRIs can be of use. I'm definitely with you as far as if conservative care isn't helping. You shouldn't be hanging out with the PT more than 6 to 8 sessions. If you're not finding some improvement by that point, then it might be time to look at other options. Like if you're, that's usually what I'll tell patients. If after 6 to 8 sessions we aren't seeing some significant improvements in your symptoms, then I need to be, coordinating with either your primary care physician or maybe your spinal physician, depending on where they've been referred into, or maybe they've come to us direct access. So we can help coordinate that too, to help get that process rolling for people who might be someone who's not going to respond to conservative care. I mean, of course, if we're biased, we think we help and cure everybody. But as Tom and I said, there are definitely people that, despite best efforts, don't quite, meet goals, and that's okay. That's just being, the human body isn't always amenable to healing, and sometimes surgical interventions can be amazing.
Yeah. On that note, be an advocate for yourself if you're a patient, right? if it's not working, it doesn't mean that it's failed. I think it means, try something different. And I think that you may find success then. The one thing I'll comment on MRI really quick is that sometimes I've encouraged an MRI after the patient has been expressing their very strong interest in it from a peace of mind standpoint. Sometimes people can move forward in a healing process if they know, or if they feel like they know the pathology better, or they can visualize it better. And I think that in that case, if they're already headed towards an MRI anyway, or if that's where you think it's going, sometimes that lets them move forward. And I think that gets in a more sort of existential sort of thing regarding it, but I do think that can help sometimes.
No, absolutely. There is definitely a peace of mind thing, and some folks do not want to move forward unless they feel like they have the answer. I mean, and again, as we alluded to, it's not as neat and tidy of your MRI equals your pain. There can be folks who have terrible MRIs and minimal pain, and some people who have, good looking MRIs and they're debilitated, can't move, and in really rough shape. So, but again, if folks are really requesting, I never have been a barrier to an MRI for somebody and saying you don't need that. I'm going to prevent you from getting one if that's something that the patient wants and feels they need as part of their care. I'm going to educate folks on what the research and science tells us about what's likely going to show up as we age in MRIs, because those things that we talked about early on are going to be there likely. Some of them, again, a good chunk of them may not be symptomatic or problems that are clinical, but that's why you have a clinical examination where somebody can physically examine you and move you to see, does this MRI make clinical sense with what the symptoms and signs that I have on a day-to-day basis? I think, unfortunately, healthcare is moving away from a good physical examination, and that's the one thing we really preach to our students and to our clinicians is to really, that you'll see that, and you get a very detailed hour-long evaluation where we'll really thoroughly look at everything that could possibly impact your condition and come up with a game plan for you. Anything you'd end with, or any other observations or things you'd like to share with the audience before we finish it up, Tom?
No, I just think that I always like these kind of conversations, and I really just hope that people, they pull one or two things out of this. They at least get some terminology, as I mentioned. They get an idea of what maybe they could look out for to help them seek care. They can get an understanding of how a therapist might approach treating them, and there's a variety there, but a lot of it can help. And yeah, I think that it's just a complicated thing. It is common, but it's not dire, as we keep trying to mention here, that a lot of cases resolve independently, a lot resolve conservatively, most resolve conservatively. Yeah. One thing we didn't mention was surgery. And
we touched upon it a little bit as far as, when folks aren't really navigating conservative care well, and it's not going as well as they need to, or those emergent cases where there's cauda equina issues where the bowel and bladder are getting impacted, or rapid neurologic loss. But I think you and I had talked about this yesterday as far as like when they've done studies of you take an acute herniation and you put 50 people or 100 people and you take 50 of them and you put them in a surgical intervention and you take 50 of them and have them go through a physical therapy process. What did the studies you look at?
Yeah, they suggested with that relative to what's called a discectomy, and that's one of your minor, less invasive herniation type surgeries and procedures where they go in, they clip off the herniation and kind of let things heal from there. But the interesting thing is what they suggested was that outcomes were equal to conservative care versus surgical discectomy after a year. The surgery tended to help things feel better quicker in those severe cases, but long-term outcomes were pretty equal. So, yeah, I think it's a decision you make with your healthcare team. And if conservative care is not helping, surgery can largely benefit people in the right hands. So I think I am pro procedures like that when the appropriateness exists.
Yeah, I think just to echo, like initially surgery tends to have more rapid relief, but in the long term, as Tom mentioned, it's pretty equivocal outcomes. But there might be factors in a human's life, a person's life, that doesn't allow them to have the ability to wait that long. There can be job-related factors, family-related factors, and that's where we got to sit down with the individual, see where their life's at and what would best serve them to.
And just remember, surgeries can get real complicated from that simple discectomy, and that adds a whole lot of variety and factors in there that we're not even touching on. So that can get a little more challenging.
Yeah, Erwin asks importance of contrast or no contrast MRI in identifying issue. I will be upfront. I am not an expert in the MRI. My understandings of contrast are more for like interarticular issues in the hip and shoulder when you really want to visualize the interior portions of a shoulder joint or a hip joint. I'm not aware of indications for the low back disc. I don't think I've ever had anybody who's had a contrast MRI for the low back personally. I think sometimes I've had folks with that question, like desperate to see there must be some tissue that was missed or something that maybe contrast will find it. But that's where it gets to the complexity of pain, especially in the back, that sometimes we don't have a good tissue explanation for some very debilitating back pain and some debilitating neck pain, and sometimes radiating into the arm and sciatica. So I've had folks where they've, very much, I'm not saying this is you, Erwin, but I've had folks where they've been really pursuing, there must be some more imaging or something that's just been missed, and understandable concerns when symptoms are horrible and life's in a challenging spot, yet the MRI is not showing a ton. But that hopefully what we showed about some of these MRIs and their lack of ability to perfectly predict pain kind of can help folks with that. All right. Well, for those of you who are watching live, thank you for joining us today. Really appreciate all your time today. For those of you who are watching this on the recording, we'd love to have any comments. If you have any comments or questions, our great social media team here at Midwestern will be peeking at the threads, and we will definitely be willing to jump into those threads and answer them if you have any questions. But again, thank you for your time, and hope to see you at Midwestern soon.
Yeah, thanks, Mark. I appreciate it. We'll see you next time, right?
See ya.